Welcome. Today we're tackling urinary and bowel elimination from the ground up. By the end, you'll understand the concepts, be able to perform the core skills, and feel ready for NCLEX style questions on this topic. This is a high yield fundamentals area, so stay with me. If you're studying for the NCLEX-PN, this is the one you cannot skip. Okay, so here's our roadmap. We'll split the lesson into two halves. We'll do urinary first and then bowel. And in each half, we will cover the why, which is the physiology, the what, we'll see the normal versus abnormal, and the skills that you will actually do, and our NCLEX reasoning. Now, keep these objectives in mind. If you can do all 8 by the end, you're in great shape. Okay, before the details, let's frame why we care. Now, there's 3 reasons. On the unit, urine output is one of the earliest warning signs we have. It drops before the blood pressure does. On the NCLEX, it shows up constantly. And for your patient, elimination is a basic physiological need and a dignity issue. How we handle it matters to them. So we'll keep all these 3 lenses on as we go. Part 1, urinary elimination. We'll trace the urinary system, learn what normal urine looks like and how much should come out, walk through the abnormal patterns and their names, and then get into the hands-on skills, specimens, catheterization, and CAUTI prevention. CAUTI is catheter-associated UTI. Now let's start with the plumbing. All right, so let's follow a drop of urine. It's made in the kidneys, which filter the blood and balance our fluids and electrolytes. Then it travels down our 2 ureters, because we have 2 kidneys, so there's 2 ureters that come down into the bladder, and the bladder stretches to store it. Our bladder is made up of muscle. Once your bladder is filled up around 300 to 500 ml, that's when we get the urge to use the bathroom. And then it leaves through the urethra. Remember, anything that blocks this path backs pressure up towards the kidney, and that can damage it. So obstruction and retention are never wait and see, right? So we follow the route. Kidneys to the ureters, to the bladder, to the urethra. If the urine is not able to come out, then it backs up, and what happens? Where does it go back? To the kidneys, right? And if pressure builds up in the kidneys, we can end up damaging our kidneys. Now memorize this number right here, 30 ml per hour. This is the minimum acceptable urine output for an adult. Anything below that, you will report it because it can signal poor kidney perfusion. Over a day, that's about 1,200 to 1,500 ml per day. Normal urine is pale straw to amber in color. It's supposed to be clear, odor, faint aromatic, which is basically that ammonia smell, but it shouldn't be anything too strong. It's slightly acidic, and dark urine, it means that dehydration. Dark urine is formed basically because we have less water, so the urine is concentrated. The dehydration. Cloudy and foul means infection, right? It should be clear. It shouldn't have any kind of foul smell. So the look of the urine will tell you a story, and you kind of have to look into it. All right, factors affecting urination. Lots of things move the dial on urination. Fluids, obviously, the more we take in, the more we put out. If you drink any caffeinated drinks or alcohol, it increases the urge, so you are urinating more often. Medications, especially diuretics, their function is to increase the output, and there are other medications that cause retention, and there are also other medications that cause color change. Chronic diseases like diabetes and kidney diseases can change it. Surgery and anesthesia often cause short-term retention because our body was asleep, so it's waking up slowly. So that's why it's short-term retention. That's one of the things that you have to watch on your post-op patients. And don't forget the human factors. No privacy and anxiety can make someone unable to go. Aging weakens the muscle tone, and when output looks off, you run through the list. Okay, now the vocabulary. This is pure NCLEX bread and butter, right? So the NCLEX will not put the wordings like, okay, little output or excessive output. You have to know these. So we have oliguria, which is scant output, less than 400 milliliters per day. Anuria is little to no output, less than 100 milliliters a day. Sometimes we see that in people with kidney failure. They will have no output because they're on dialysis. Polyuria is excessive output. They're going a lot. Dysuria is painful or difficult urination. Nocturia is waking to void during the night. Frequency or urgency. Frequency is voiding often. Urgency is sudden, strong need to just go. And then you have retention, which is the bladder can't empty fully, so the urine stays in. And uresis is basically involuntary urination, often at nighttime. This is bedwetting, seen commonly in young children. All right, so urinary retention. So the bladder fills, but it won't empty, right? Some of the common causes, like I mentioned in the previous slide, are after surgery and anesthesia, with an enlarged prostate, or with certain medications. So you'll see a distended bladder, suprapubic discomfort, and sometimes frequent little dribbles, and that's called overflow. So what you as a nurse, you'll do is that you'll scan the bladder, give privacy and time, try running water or pouring warm water over the perineum, and get them up and moving. You only catheterize if it's ordered, and the red flag is that if a post-op patient hasn't voided in 6 to 8 hours and is with a full bladder, so you have to act on that. Like I said, post-op anesthesia, it's short-term retention. And so you want to watch out for that. If they haven't voided for a couple of hours and they say that their bladder's full and they can't go, right away, get the bladder scanner, scan the bladder, see how much they have retention, and then the physician will usually order you to straight cath them. And if it's a long-term condition, obviously, just catheterize them. Okay, so urinary incontinence. This is something that you also have to know, comes up on the NCLEX a lot. So there's 4 types of incontinence to keep straight, right? Stress, leaks when abdominal pressure spikes, coughing, sneezing, lifting. Sometimes a lot of women after pregnancy, postpartum, they experience it. The urge is a sudden overwhelming need and they can't hold it. Out of nowhere, they just get an urge to pee, and they go. So that's an overactive bladder. Overflow, the bladder is so full it just dribbles. It is tied to retention. They can't fully let go of the urine. Some of them is still filled in, and so what happens is that it just continues to dribble. It's basically like having a water bottle and it's still full, but you haven't closed it properly, and so it's leaking. All right, functional is the bladder works fine, but the person can't get to the toilet, maybe mobility or dementia. The tip-off in a question is the trigger. A cough means stress. A sudden urge means obviously urge. A walker in a far bathroom means functional. So somebody has a proper functional bladder, but they're not able to make it on time either because they're not able to walk. They're not able to, they forgot to use the bathroom and then they don't know where it is. So yeah, remember these. UTIs. Classic signs are dysuria, which is painful urination, frequency, urgency, cloudy foul urine, and suprapubic pain, sometimes fever. Fever would come in basically if they've had the UTI for a very long time and it's been left untreated. So one of the biggest NCLEX trap is that in older adults, a new onset confusion may be the only sign. So don't wait for the textbook picture. The catheter is the #1 cause of hospital UTIs. So we follow the CAUTI bundle. We do hand hygiene, sterile insertion, closed system bag below the bladder, tubing secured, daily pericare, and the most powerful step of all is that get that catheter out as soon as you can. The best catheter is no catheter. So older adults, new confusion may be the only sign because, again, they might not be able to tell you that they're having dysuria or their frequency and urgency. If they're just emptying their bladder, we could think that that's, because of aging, that also happens. So that's why if an older adult just develops a new onset confusion, then check for UTI. All right, 2 assessment tools, intake and output. You're going to record everything, oral, IV, tube feeds, and everything out. Urine, emesis, drains. If they are wearing a diaper, remember that 1 ml is equal to 1 gram. So you can weigh a wet pad to estimate the output. Read your graduate at eye level on a flat surface. Basically, if you have a container or if the patient has used the urinal, put it on a flat surface. If you're holding it up, obviously you're not going to get an accurate reading. Then the bladder scan. It's a painless ultrasound that tells you how much urine is left after voiding. The post-void residual. This is huge. We scan before we reach for a catheter. Assess, then intervene. Like I said, you just don't want to catheterize without knowing if they're really holding urine in or not. So you want to make sure with the bladder scanner, because as nurses, our nursing process, we follow ad pi. We always assess first. If upon assessment we see that the patient is retaining urine, we obviously let the physician know the amount, and then if we get an order to catheterize, sure, if we can help them in any way to void in the bathroom, make them walk, we do all that. All right, specimen collection. The type of specimen collection, it depends on the test that's been ordered. For routine urine analysis, it just needs to be a clean container. For a culture and sensitivity, you need a clean catch midstream. So you cleanse, you start the stream, then catch the middle, so you skip the contaminated bit first. From an indwelling catheter, you aspirate from the sampling port with a sterile syringe. Never ever from the drainage bag, because that urine is old and contaminated. And the 24-hour collection, you discard the first void to start the clock, then save everything for 24 hours, usually on ice, ending with a final void. If you mess up the start or the end, the whole test is invalid. And there are 4 urinary catheters. There's the straight or intermittent catheter that goes in, drains, and comes right out. It's great for one-time empty or checking residual. The indwelling Foley, it stays put. It's anchored by a little balloon and it's draining continuously. The suprapubic is surgically placed through the belly for long-term needs. And the condom catheter just slips over the penis, is external, non-invasive, and carries far less infection risk, but you still watch the skin underneath. Remember, insertion of internal catheters is always sterile technique because we're inserting it inside the organ. All right. And for the condom catheter, the reason why we check the skin is because it's as it's draining, the skin around it, it doesn't dry up completely. It stays moist. So you want to see that there's no skin breakage. because of too much moisture. All right, so inserting an indwelling catheter. This is a big sterile scale, right? So first of all, most important thing, perform your hand hygiene, explain to the patient what you're about to do, and make sure they're in the right position. For females, it's dorsal recumbent. For males, it's supine, and make sure you get good lighting. We need it, especially for females. And then you open up your kit, glove up, sterile, drape. Use your non-dominant hand to separate the labia or hold the penis. And once it touches the patient, remember it's contaminated, so it does not move. With the sterile hand, cleanse from front to back. Then insert, for females, about 2 to 3 inches until urine flows, then a little bit more. For males, about 6 to 7 inches, holding the penis at 90 degrees. And the golden rule, the thing that they test is that you inflate the balloon only after you see urine, because you might think that you're in the bladder, right? And then you end up inflating. You could accidentally inflate the urethra, and that will cause injuries to the patient. So unless you see urine first, you're not inflating, and there will always be urine in the bladder. The bladder is never completely empty. That's one of the NCLEX questions. All right, now how do we care for an indwelling catheter? So once the catheter is in, the work continues, right? You need to do daily pericare with soap and water, cleaning the catheter from the meatus outward. You want to make sure that the bag is below the bladder and off the floor. That prevents urine from flowing back up. You want to anchor the tubing to the thigh and watch for any kinks and dependent loops where urine will pool. Make sure the system is closed. You want to empty it regularly using a clean, separate container for each patient. And then reassess daily and remove it early. If the patient doesn't need it, if there is an order to get it removed, do it right away, because every one of these is a CAUTI prevention step. Okay, so here we have a question on catheter safety. Now, think about gravity and closed system, right? An older adult has indwelling urinary catheter. Which nursing action best reduces the risk of catheter-associated UTI? Right, so which option keeps urine flowing down and the system sealed? Hang the drainage bag on the side rail above the bladder. Disconnect the tubing each shift to obtain a urine sample. Keep the drainage bag below the bladder with tubing secured. Irrigate the catheter with sterile water every shift. Now, you can pause the video and pick your answer before you continue. I will give you 5 more seconds and then move on to the next slide to look at the answer. All right, so our answer is C. Keep the drainage bag below the bladder with tubing secured. Bag below the bladder, tubing secured. We need a closed system. A reverses gravity, right? Because the bag above the bladder will let the urine flow back towards the bladder. B and D both break the closed system, which is exactly how bacteria gets in. Notice the strategy, right? When in doubt, the answer that keeps the system closed and undistributed is usually right. Question number 2, post-op retention. Remember that assessment comes before intervention, and we always pick the least invasive correct step. So 4 hours after surgery, a client has now voided and reports lower abdominal fullness and pressure. What's the nurse's priority action? What is the first thing that you'll do? A, document the finding and reassess in 4 hours. B, perform a bladder scan to assess for retention. C, insert an indwelling catheter right away. D, restrict the client's oral fluid intake. You can pause the video and pick your answer before continuing. We'll move on to the next slide. The answer is B, perform a bladder scan to assess for retention. The whole question is testing the nursing process. Assess before you act. The scan is painless and tells you if retention is real. Catheterizing is invasive and needs an order, so it cannot be your first move. Waiting delays care, and restricting fluids makes no sense. So least invasive assessment that gives you the data, that is your priority pick. All right, so part 2, bowel elimination, is the same structure. We'll trace the GI tract, learn what normal stool looks like using the Bristol scale, cover constipation, impaction, and diarrhea, and then the skills. We'll look at specimen collection, enemas, suppositories, and ostomy care, plus the finding that needs to be reported right away. Okay, so how is stool formed? So let's do a quick tour of the GI tract. The stomach turns the food into chyme. The small intestine, it absorbs nutrients, and the large intestine, which is the colon, pulls water back out and forms a stool. Then it's stored in the rectum and expelled. So here's the key idea, right? The colon's job is water reabsorption. If stool races through too fast, there's no time to absorb water and you get diarrhea. Too slow and it gets hard and dry, which is constipation. And normal is a wide range, anywhere from 3 times a day to 3 times a week. It can be perfectly normal. All right, so normal stool is brown, soft, but formed and shaped like sausage. Sorry about the TMI. And it passes without straining. So the Bristol stool scale, it gives us a shared language. Types 1 and 2 are hard lumps, that's constipation. Types 3 and 4 are the ideal, smooth and soft. Type 5 is soft blobs, usually means not enough fiber. And type 6 and 7 are mushy to watery, and diarrhea, it could be diarrhea. And then we look at the color. Brown is normal. Black and tarry means an upper GI bleed, or iron or Pepto-Bismol. Bright red is lower GI, and clay colored or white means bile isn't getting through. Now, color is a clue you report. What affects bowel movements? We know diet and fiber. Fiber adds the bulk that keeps things moving. Fluids, too little, and the colon pulls all the water out, leaving hard, dry stool. Activity, moving around, literally stimulates the gut, which is why immobile patients get constipated. Remember that. Medications matter a lot. Opioids and iron constipate. Antibiotics often cause diarrhea. And then we will remember our routine and privacy. Ignoring the urge throws off the rhythm, and surgery and anesthesia slow the bowel down. Now this list explains most of the problems we'll see next. All right, so constipation and fecal impaction. Constipation is infrequent, hard, dry, hard to pass stool, and it's caused because of low fiber and fluid, inactivity, opioids, or ignoring the urge. If it isn't managed, stool can harden into an impaction, which is a mass that can't move. And here's a trick question, right? The sign of impaction is often a liquid stool leaking through the mass. So the patient will seem to have diarrhea, but they haven't actually had a real bowel movement. So you want to treat it with fiber, fluids, movement, and softeners. The last resort is digital removal. So because it needs an order, and sometimes it can slow the heart through a vagal response. In case of you performing digital removal of impaction, you have to monitor the pulse and stop if it drops. All right. What is diarrhea and C. diff? We hear about C. diff all the time in the hospital. Diarrhea is frequent loose watery stool, and the dangers are dehydration, loss of electrolytes, especially potassium, and skin breakdown from the constant moisture. Now, the causes range from infection to medication to tube feedings. Nursing care is to replace fluid and electrolytes. We want to protect the skin with barrier cream. We watch the intake and output, and we're always washing our hands. C. diff requires content precautions. A foul-smelling, watery diarrhea will make you think C. diff. You must wash your hands with soap and water because alcohol gel does not kill the spores, and because it's contact precautions, gloves, and gown. All right, two more. We have bowel incontinence and flatulence. So bowel incontinence, it's involuntary stool. It comes from nerve or muscle problems, cognitive issues, or overflow around an impaction. Your priorities as a nurse is to protect the skin, and you want to start a bowel training schedule. For flatulence, which is trapped gas, it's super common after surgery. We can provide relief by ambulation and position changes help, and sometimes rectal tube. So we have a clinical pearl that's an NCLEX favorite, and that is the return of flatulence and bowel sounds after surgery. Tells you peristalsis is waking back up, and that's the milestone you watch for before advancing a diet. So NCLEX question could be, after surgery, you only provide the patient with food. I'm sure they're gonna wake up hungry or thirsty only after they're able to pass gas, or if you're able to hear some bowel sounds. All right. Administering an enema. So cleansing enemas. We have tap water, saline, or soap suds. They empty the colon. A retention enema, usually oil, is held to soften. Hard stool or return flow enema relieves gas. And to give one of the enemas, you want to position the patient on their left side in Sims position, because that allows that follows the natural curve of the colon and helps the solution flow in. Remember, left side, not right side. The NCLEX could trick you. Say right side Sims, left side Sims, the left side Sims. Hang the bag about 12 to 18 inches above the anus. Lubricate and insert tube 3 to 4 inches and let it run slowly. The classic test point is that if they cramp, lower the bag and slow the flow, because cramping means that the fluid is going too fast. And don't pull the tube. Suppository and digital removal. So a rectal suppository, you want to glove up, lubricate it, and position on the left side and insert it. Remember, anything that goes up in the rectum, the patient is positioned on their left side. Sims. It's called Sims position, but left side. All right. So you insert it past the internal sphincter, about 4 inches in an adult, placing it against the rectal wall, not into the stool. Then have patient hold it so it can dissolve and work. Digital removal of an impaction is more serious, right? It needs an order. You go gently, and the key safety point is that stimulating the rectum can fire the vagus nerve and drop the heart rate. So you monitor the pulse the whole time and stop immediately if it slows or the patient complains of feeling faint. We have ostomies. A colostomy is on the colon, so output is more formed. An ileostomy is higher up, so the output is liquid and full of enzymes, which is rough on the skin. So skin protection is a bigger deal there. Now, the assessment that gets tested is that a healthy stoma is pink to red, moist and slightly raised, and the little bleeding when you clean is normal because it's vascular tissue. The red flag is that the one you'll see in questions is if it's pale, dark, dusky, or purple stoma. That means the blood supply is compromised, is ischemic, and you have to report it right away. Also, empty the pouch at about 1/3 full. Okay, now we have a question on enema. All right. While administering a cleansing enema, the client reports abdominal cramping. What should a nurse do first? Now think about why cramping happens during an enema. If the flow is the problem, what's the gentlest fix? That still lets you finish. So what would you do? Would you stop the procedure and remove the tubing immediately? Would you raise the enema bag higher so it finishes faster? Would you lower the bag and slow or briefly stop the flow, or continue at the same rate and reassure the client? Now feel free to pause the video, think about an answer, and I'll move on to the next slide. Okay, so the answer is C, lower the bag and slow or briefly stop the flow. So cramping during an enema almost always means it's flowing in too fast. So the fix is to lower the bag and slow it down, then continue when the cramping passes. You don't pull the tube unless slowing doesn't help, and B makes it worse by speeding the flow, and D ignores a fixable problem and risks them losing the solution. So you never dismiss a patient's complaint. All right, question number 4 regarding a stoma. The nurse assesses a client's new colostomy. Which stoma finding requires immediate notification of the provider? Right, so picture a healthy stoma in your mind. It's supposed to be pink, red, and moist. Now, which of these is the opposite of healthy circulation? Is it pink, moist stoma, red, slightly raised stoma, dusky purple, blue stoma, a small amount of bleeding when cleaning? Now go ahead and pause the video, think about an answer, and I'll move on to the next slide. So the answer is C, dusky purple, blue stoma, right? So that color changes, it screams, what does it scream? Compromised circulation. The tissue isn't getting blood, and that's an emergency, you escalate. Pink and red stomas are exactly what you want to see, so A and B are normal, and D, minor bleeding during cleaning, we mentioned is normal because the stoma is vascular, so that means it's packed with blood vessels. Color is everything with stomas. Remember, pink, red, good, dusky purple, bad. All right, so let's consolidate on the things you never sit on. The report immediately list. So urine output under 30 an hour will report a post-op patient who hasn't voided in 6 to 8 hours with a full bladder, cloudy foul urine with fever or new confusion in an older adult, a dusky pale or dark stoma, black tarry or bright red bloody stool, no bowel movement, but liquid leaking, that's impaction, a slowing pulse or faintness during digital removal, and watery foul diarrhea, you think C. diff. If you see any of these, you escalate. When in doubt, you report. Okay, now let's lock in the 6 things to walk away with. 1, 30 ml an hour is the floor for urine output. It's the minimum, all right? 2, with a Foley, the balloon goes up only after you see urine. 3, bag below the bladder plus a closed system is your COTI mantra. 4, Bristol 3 and 4 are ideal, and black or red stool gets reported. Number 5, enemas and suppositories go in the patient on their left side, and cramping means slow the flow. 6, a healthy stoma is pink, red, and moist. Dusky or purple is an emergency. All right, that's the full picture on urinary and bowel elimination. If this helped things click, do me a favor, give it a like, hit subscribe and turn on notifications so you don't miss the next review. I post new NCLEX-PN walkthroughs every week. Drop your questions in the comments. Tell me what topic you want next, and I'll see you in the next video. You've got this.